Good afternoon, everybody. Thank you very much for joining me. My name is Dr. Chris Jenner. I'm a consultant in pain medicine at Charing Cross Hospital. And today we're going to be looking at why some medico-legal claimants are predisposed to developing chronic pain. So, little agenda, we're going to talk about what pain is, a little bit of pain physiology. We'll have a look at the anatomy of a pain report. We'll get into some of these factors, vulnerability and resistance. We'll look at some of the conclusions that we come to in a pain medicine report, the range of opinion, biopsychosocial model, causation, prognosis and treatment. And we'll make sure that we've got plenty of time at the end for questions. So let's start off. So what is pain? So it's defined as an unpleasant sensory and emotional experience which we primarily associate with tissue damage or describe in terms of tissue damage or both. Now, obviously, that is quite a mouthful. That's the IASP, the International Association for the Study of Pain definition. A more useful definition when you're dealing with patients is pain is whatever the patient says it is, and we'll come across that in a minute. Pain has a time course. There's acute pain, which by definition is less than 3 months, and chronic pain, which is basically all your medico-legal cases, which is going to be 3 months or more. And there are two major types of pain. There's nociceptive pain. That's where the nerve, the pain signaling pathways are intact and functioning, and neuropathic pain, where those pathways are damaged and or dysfunctioning. The difference is nociceptive pain is things like neck pain, back pain, whiplash, joint pain, etc., etc. Neuropathic pain, the pain levels are much higher. Patients will talk about sort of burning, stabbing, lancinating pain, electric shock-like pains. They have very high pain scores. They may have sensory dysfunction associated with the pain. And these are the conditions, particularly in medico-legal practice, things like post-amputation pain, post-surgical pain, complex regional pain syndrome, CRPS, and other similar conditions. So when you get a report in pain medicine, what do you get? Well, first of all, we start off with a summary of the case, which generally you will helpfully send us. I will do a detailed review of the Preindex accident or Preindex event medical records. We'll call it accident here. I also do a detailed review of the Postindex accident medical records. I will look through all the expert witness reports, so we'll divide them into claimants and defendants, any witness statements, and then we take a history from the patient. So this starts off by sending out the patient's questionnaires in advance of their assessment. They will return those, and then I can put those into the report. So we're looking at things like the pain characteristics, so site, character, duration, radiation, aggravating, relieving, associated factors. So as you can imagine, it's all the basic medical history or medical questions that we want to know about that patient's experience and feeling of pain. Next big thing we do is I will see the patients face to face. We have been open for several months now, seeing patients face to face, and that will include a general examination. So that's how they are, how they got to the assessment, their sort of walking, posture, gait, their affect, how they are, if they've brought somebody with them, if they've got a chaperone, etc., etc. So all the general examination aspects. I'll then do a targeted examination. So obviously if the patients come in because they've got a whiplash injury, then we'll do a detailed physical examination of the neck and of the upper limbs, and the neurological examination of the upper limbs, for example. And then what I'll also do at these assessments is ask them further questions. So we've already asked them a lot of questions, but I tend to go over their history and get them to tell me further information in their own words. And by that method, we can get a very round picture of the patient's pain, how it affects them, how it affects their functioning, their daily activity, their employment, their care requirements, what they are and aren't able to do. And we'll also look at, you know, their functioning within the home, ability to use the toilet and go out and socialize, and etc., etc. So we'll get a very broad amount of information about their presentation with pain. So this topic of vulnerability and resistance. So unfortunately, there are a number that we need to go through, but I think hopefully you will start to recognize in your own claimants some of these. So demographics, age, well, these are vulnerabilities to the development of chronic pain, which we said at the beginning is pain that lasts for more than 3 months. So demographic things, age, well, as people age, they are more likely to get chronic pain. Simple example, you're more likely to get back pain, joint pain, hip, knee pain, and as you get older. Gender, there are some gender biases. So for example, with things like fibromyalgia, there's about 3 females to 1 male. Preponderance for somatic symptom disorder, it's actually about 10 to 1. Social isolation can be associated with the development of chronic pain. Poverty, unemployment, job dissatisfaction, patients' accommodation, their diet. Vitamin D is a potential reversible cause, and poor health habits. Patients who have a chaotic lifestyle. Patients who have raised body mass index, so basically they're overweight. As you can imagine, they have a greater propensity for developing chronic pain, particularly lumbosacral pain, that is back pain, knee pain, hip pain. Patients who do very little physical activity are more prone to get chronic pain. And then there are physical factors, sleep disturbance. So people who have chronic insomnia are associated with higher incidence of chronic pain. And substance use, and that includes alcohol, cigarettes, recreational drugs. This tends to be associated with higher levels of chronic pain. If the claimant has a pre-existing pain history, i.e. they've either previous multiple episodes of pain, or they have ongoing pain in the background, then they are more likely to develop chronic pain. For example, after an accident or an event, surgery, or other issue. Mental health issues, patients who have anxiety and depression are more prone. Cognitive ability, attitudes and beliefs about pain can be very important. And patients who have relationship difficulties are more likely to develop chronic pain, as are those who are subject to abuse, particularly verbal abuse and violence. So as you can see, there are a wide number of risk factors associated with a patient developing chronic pain, and that's after any initiating event. Most of this is looked at in patients who are not in the medico-legal arena. So if you can imagine, patients can have these risk factors, but then you put on top of that the stress of litigation. it gives them yet another potential risk factor for the development of chronic pain after an accident or other event. And this is important. It'll come up later on, this idea of causation. When we think of causation in medicine, we're thinking of etiology. Well, what's caused it? So you've got flu. Why have you got flu? Well, the etiology, the causation is a flu virus, and that's it. We know there is a relationship between the disease process and its causation. However, risk factors are different. Risk factors are not absolute. Risk factors say that the likelihood that you will develop chronic pain is modified by different risk factors, and the amount of risk is not completely determined. We just know that there is an association between certain risk factors and the development of chronic pain. And generally speaking, and this is a big generality, generally speaking, the more risk factors that a patient has, the more likely statistically that they will develop chronic pain. And as I said before, that doesn't even take into the account the fact that a lot of these claimants are in the medico-legal process and what risk factor that will add in there. Now, I'm just going to go back to these vulnerabilities. Basically, if you want to know what factors will give resilience to a patient to prevent them from developing chronic pain, basically you go to our table of vulnerabilities and you reverse it. So less likely if you're younger, less likely if you're male, less likely if you've got better social contacts, if you're affluent, if you have a job which is a good job, which you enjoy, if your accommodation is up to scratch, if you've got a good diet, if you've got good health habits, and so on and so on. So what can we conclude from all this information that we present you with in a pain medicine report? Well, first of all, we look at the claimant in the pre-accident time period. So what we're most interested in is, what are the pain-related entries? Were they going to and from their GP with pain issues? Do they have any psychological and psychiatric entries? So that can be anything. General things are going to be anxiety, depression, substance misuse, other psychiatric conditions, stress, big one these days. And then we look at other health issues, but they're the main three things that we're looking at pre-index accident. And then the actual accident or incident itself, well, again, thankfully, you very kindly send us very helpful summaries, and those summaries are very, very useful because as you can imagine, and I'm sure you see, the claimants often don't have a clear recollection of exactly what's happened. And so when we get the instructions which give us a clear few paragraphs which say exactly what happened, exactly what the aftermath was, that can be extremely helpful for us, because obviously everything runs in the medico-legal case from that initial event. We also look at the contemporaneous records. So for example, A&E records, GP records, hospital records, accident book records, if those are available. And probably the least most useful is the claimant's description. I will still take a history from the claimant about the accident or the incident, but with all those little bits of the jigsaw, you can get a good, robust idea of exactly what happened at the time of the event. And then post-index accident summary. What we're really looking at is what happened. So you're in a car crash, you had an operation that went wrong, you had, fell off your skateboard, whatever it happened to be. What was the immediate medical attention? What happened in the first few hours, few days, few weeks following the index event? And then how did that evolve? So you are where you are at the moment. We've taken your history. We know about where your pain is and how it affects you and your pain scores, etc., etc. So we've got a really good understanding of your presentation with pain. But what we want to know is how that has evolved from the onset of the event until the current time. So when we come to diagnosing pain conditions, we can divide them into fairly big categories. So if you remember, we spoke about nociceptive pain at the beginning. So nociceptive pain, as we said, is where the nerve signaling pathway, that little video that I showed you, all of that is intact. It's all working, it's functioning, there are no problems with it. So that is, again, things like whiplash injury, lower back pain, knee pain, etc. Musculoskeletal pain is a very good example of that. And then, is it that, or is it neuropathic pain, which, as we said, is that there's damage and or dysfunction of elements of the nervous system, which basically lead to hypersensitivity of the nervous system and characteristic presentation with neuropathic pain, the sharp stabbing, burning pain, etc. There's another category where claimants can have a mixture of both nociceptive and neuropathic pain. And this thing down here, the ICD-11, has become very useful. ICD is the International Classification of Disease. It's in the 11th version at the moment, and that's been provided by the World Health Organization. And my colleagues and I actually have started to find this increasingly useful when we're asked by the courts to classify claimants' pain, like put an actual proper label on it, because they have provided us with some very useful definitions. So I'm not going to go through these exhaustively. This is literally a handful of some of the main pain categories that exist in the ICD-11. The ones that I have highlighted in yellow here are some of the more common categories that we will use in medico-legal reports. And we'll go through each of these. So we've got chronic primary pain, chronic post-surgical and post-traumatic pain, and chronic neuropathic pain. And just for completeness, they're literally, if you go onto the ICD website and just type in chronic pain, you will get a huge list, which then subdivides and subdivides again. So, you know, we're not at a loss for descriptive labels. Other ones here, phantom limb syndrome. I had one of these recently, and we realized that the ICD-11 has recategorized, because you can actually call it chronic neuropathic pain, you can call it chronic post-surgical pain, you can call it chronic post-traumatic pain, you could also categorize it as phantom limb syndrome. So you know, you can categorize patients' pain in more than one place using ICD-11. So let's talk about chronic primary pain, because I would say this is one of the commonest pain conditions. Some people like to call them pain syndromes, but pain conditions that we diagnose in medico-legal practice. So by definition, chronic primary pain is chronic pain, as we said, more than 3 months, in one or more anatomical region that is characterized by significant emotional distress or functional disability. It's multifactorial, biological, psychological, and social factors contribute, and it can be used independently or in addition to other diagnostic labels and descriptors. Chronic post-surgical pain or post-traumatic pain. So this is going to be patients that have been in a head-on car accident, patients who have had an operation and they've developed severe pain following that. So chronic post-surgical or post-traumatic pain is pain developing or increasing in intensity after a surgical procedure or a tissue injury, and persisting beyond the healing process, which I'm sure you're very familiar with, i.e. at least 3 months, 12 weeks after surgery or tissue trauma. Excuse me, generally 12 weeks is the time we're given for most tissues to heal. That's a generality, but generally speaking. And then chronic neuropathic pain. So this is chronic pain caused by a lesion or disease of the somatosensory nervous system. The pain may be spontaneous, i.e. come on its own, or revoked, i.e. if you move the affected area, and you can have an increased response to painful stimuli. So for example, if you do a pinprick sensation on somebody who has neuropathic pain in their arm, their arm will fly across the room because it's so painful. Or if you did light touch sensation with a bit of cotton wool, they can find that to be painful. So those are two examples of hypersensitivity, and hypersensitivity is very commonly associated with neuropathic pain. The fear avoidance model of pain. So if you look on the right hand side, what's supposed to happen is you have an injury, you have a pain experience, so you experience pain, acute pain, you have very little fear, you confront it, your tissues recover and heal, and overall you have a recovery, and that's the end of it. That's what's supposed to happen. That is biologically how we've been designed. Well, all organisms are designed to be injured and to ultimately recover from it. Now, the fear avoidance model says that some patients, particularly in the medical legal process, will have an injury, they will have an experience of pain, they may catastrophize about the pain, so they will have excessive thoughts about the pain, they will ruminate about the pain, they will talk to all their friends about the pain, they will be distressed by their pain. This may lead to a fear of movement, because they may erroneously think if I move my back, it's going to injure it and I'm going to be in a worse situation. They avoid activity, they become hypervigilant, and they may start to disuse the limb or the spine or whichever part of the body, and then they will start to get psychological and psychiatric morbidity, particularly depression and anxiety. And then unfortunately the claimants will roll around this this loop and essentially not overall improve. Now, when we look at pain reports, we'll often give an opinion as to what pain issue or issues we think are going on, but also we need to come up with a range of opinion. We call it differential diagnosis. I will tend to categorize it as this: biological and organic causes. So for example, if somebody comes along that's had, let's say, a fracture to their ankle and they've ended up with complex regional pain syndrome, the range of opinion would be biologically they have CRPS, complex regional pain syndrome, or they have neuropathic pain, or they have mixed nociceptive and neuropathic pain, or they have a nerve entrapment, or they have some other organic cause. Psychological and psychiatric range of opinion may be that they have SSD, somatic symptom disorder, which we're going to talk about in a little while, or they may have a mood disorder or an adjustment disorder or some other psychiatric issue. The non-biological, non-psychological, essentially what we're saying here is there an element of exaggeration? And as you know, It basically goes from unconscious exaggeration at one end to fully conscious exaggeration and frank malingering at the other end. So we do have to look at all these potential explanations for the patient's pain. And if you don't, your opposite number certainly will, particularly if they're there for the defendant. So let's just talk about SSD. The reason I want to do this is it's coming up increasingly in pain cases. So SSD is somatic symptom disorder. So somatization is a process by which psychological and emotional distress, so basically a psychological issue, will manifest in the patient with physical symptoms which are otherwise medically unexplained. Pain is one of those symptoms. So, for example, with SSD, patients can have pain, they can have all manner of different physical complaints, and they may well end up going around multiple hospital units, getting various investigations. They all come back negative, 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 negative. We can't find a cause for your bowel problem. We can't find a cause for your balance problem. We can't find a cause for your XYZ, whatever problem it is, because actually it is a problem to the patient, but actually its cause is ultimately psychological. This is a diagnosis that we see increasingly in pain medicine reports. The experts that would deal with this are our psychiatry colleagues, because there are, as you can imagine, scoring systems and checklists in order to diagnose somebody with somatic symptom disorder. And it's a totally relevant and reasonable diagnosis. If you have a patient who has chronic primary pain, which we talked about before, it's chronic pain, they've got it for more than 12 months. It's got a psychosocial aspect to it, which is significant. It hugely interferes with their level of functioning. Well, there is an overlap with how a patient would present with SSD, with somatic symptom disorder. And it's always interesting because obviously you will see a pain report from a pain medicine perspective saying this person, I think, has chronic primary pain. When the psychiatrists look at the exact same patient, they have access to all the same records, do a history, do everything the same way, but looking at it from a different perspective, they may diagnose somatic symptom disorder. Still recompensable, but we do need to consider it as part of the differential diagnosis. Somatic symptom disorder is common. As we said earlier, it's a more higher propensity in females. There's also heightened awareness of other bodily sensations and a tendency to interpret these as indicative of medical illness. The patients have excessive thoughts, feelings and behaviors associated with those symptoms, and as we said before, they will end up, they are what we call prolific users of healthcare resources. They'll go back to and from their GP, to and from their hospital, having various investigations. So we move on. This brings us into the biopsychosocial model of pain. So just saying, oh, this patient has pain, what does that mean? Oh, well, they got back pain, they got neck pain, they got leg pain. It doesn't really fully give the picture of their presentation with pain, because actually the pain that they experience is only part of it. There is an overlap between biological factors, psychological factors, and social factors. And in these cases, it's important for us to look at the biopsychosocial model of pain and look at what biological, psychological, and social factors that individual claimant has, and overall build a picture of their presentation with pain using this model. The old model was the biomedical model. Now, the biomedical model basically says, okay, so you're in a car, you have a car accident, you get a whiplash. The biomedical model says you have pain for X amount of weeks, then you get better, then that's the end of it. And anything beyond that, well, must be due to other factors. It's not all encompassing. It's not looking at the psychological makeup of the claimant. It's not looking at them, their care at home, their relationships, their employment in particular, and their activities of daily living. It's not giving you that full picture. So we've gone through that. Causation. Generally speaking, in pain cases, there will be a primary expert, and so, you know, for a lot of trauma type cases, that will be the orthopedic expert, and we will always defer to the expert witness in orthopedic surgery for matters of causation. So, for example, if the patient has been in an accident and they've fractured a bone, the orthopedic surgeon will be able to say to us, yeah, the expected recovery time is this many weeks for this type of fracture. After that, there should be some residual problems, and then, you know, it should be pretty much resolved. There may be a bit of excessive, extra pain for some period of time, but then over time that will diminish. As pain experts, we come in because these claimants have not got better in the expected period of time that would be expected by my colleagues in orthopedic surgery. And so we need them to comment on the initial issue, but then we kind of take the baton over as to when these patients get past 3 months and they're not getting any better. Excuse me. Likewise, we will defer to the expert witnesses in psychiatry. In medico-legal practice, it is very, very common for claimants to have coexistent psychological and psychiatric morbidity. So as we mentioned before, depression, very common, anxiety, very common. A lot of these claimants will have some sort of adjustment disorder, some sort of PTSD, definitely under stress, if for no other reason but for the medico-legal process. So we will defer to them for these matters, and hopefully we can all work dovetailing each other's opinions and assisting one another to build up a picture of what's happened to the claimant and where they've finally ended up. So the prognosis, as I said before, all of your claimants, if they have pain, are going to have chronic pain by the time they, you know, end up in the medico-legal process. So from a prognosis wise, we're really looking at X many years and Y many months have lapsed since the index accident. Inevitably, that's going to be greater than 3 months, and therefore they're going to have some sort of chronic pain issue. What we will usually say is that on the balance of probabilities from a pain medicine perspective, the claimant's pain is unlikely to spontaneously resolve. Once a patient has had pain for 3 months or more and they're categorized as chronic, essentially, if you don't give that claimant any treatment at all, their pain will essentially grumble on indefinitely. It just won't get any better or worse. It may get worse, but it's certainly not going to resolve on its own. And so the likelihood that a claimant who has pain for 2 years, 3, 4, 5+ years, the likelihood that they will, sounds ridiculous, but wake up one morning and all their pain has gone is remote. It doesn't really happen. So we'll just talk a little bit about treatment. So as an overview, we use a multidisciplinary team approach. So that's to say, in an average pain clinic, it's not just a pain doctor. You'll have pain physiotherapists, pain psychologists, pain nurses with specialist interests, for example. And some of the treatments that we use, pharmacological treatment is used a lot. We've got a wide variety of medications that we use. We use opioids, weak opioids, strong opioids. We use anti-neuropathic medications, anti-inflammatories, muscle relaxants, antidepressants, all sorts of different medications we use. Excuse me. Multimodal analgesia is where you use more than one analgesic medication, usually a variety, targeting different aspects of pain, overall to try and provide a therapeutic result, a beneficial therapeutic result. Psychological therapies, this is really the domain of clinical pain psychology, and this may include counselling, CBT, EMDR, and other techniques. Minimally invasive pain management procedures, as you can see, an excessive number of pictures there. This is something that I do a lot of. I've been in the NHS this morning, so we spent the morning injecting people with various things, steroid preparations, local anaesthetic, Botox, using pulsed radiofrequency treatment, which is at the bottom right-hand corner. That's a non-destructive electrical treatment to treat pain. And we can talk about that in more detail if you wish. There's also advanced pain medicine procedures. So some patients who have very severe what we call refractory pain, i.e. they've gone through all the general pain treatments but failed, they may be amenable to more advanced things. So these are things like spinal cord stimulation, peripheral nerve stimulation, intrathecal implantable pumps. And most importantly, physical therapy. I mentioned earlier that we work a lot with pain physiotherapists. In my simplistic mind, what we do is we get patients, we treat them, we try and get their pain under as good a control as we can. We reduce the experience of pain as much as we can, because ultimately we need to get that claimant, that patient, into the clutches of the pain physiotherapists, who are then able to properly rehabilitate them. As you can imagine, if you have a patient with very severe pain, let's say they have very, very severe lower back pain, you can't do anything with them. You can't rehabilitate them. You can't do core stability. You can't get them to walk or run or pretty much do anything. So as a pain doctor, my role really is to reduce that pain as much as I can for as long as I can, using any and all of the techniques at my disposal to try and get that patient's pain as much under control as possible, so we can then move on and rehabilitate them. This is all physical rehabilitation, but as you can imagine, there's an awful lot of psychological rehabilitation will go into physiotherapy treatment at the same time. So, you know, obviously you will develop a rapport with the pain physiotherapist. You will see your progress. They will be very encouraging to try and get you better and rehabilitate and fulfill various physical goals. And along the way, hopefully your mood will improve, your affect will improve, your motivation will improve, you'll see that you're getting better, and overall you'll get physical and psychological rehabilitation. And ultimately, that will boil down to functional improvement. The patient's able to do more, they require less care, and hopefully get them back to employment, which we're going to talk about. So current activities of daily living, as I said at the beginning, this would be part of the history, to take a detailed history of what patients are able to do. Future employment, it's important. We're always, when we come to treatment, we look at multidisciplinary treatment with a view to getting patients back to the workplace. It's got lots of benefits, as you know, psychological benefits, physical benefits, social benefits, financial benefits. And it also will affect the value of a claim very, very significantly, whether or not a patient can or can't go back to the workplace. Future care requirements. So future treatment aims to minimize multidisciplinary treatment aims to minimize a patient's future care requirements. We want to make patients as independent as possible, reduce their care requirements, which has a knock-on physical and psychological benefit to them. Certainly, they may require assistance with heavy domestic tasks. That's very common. And in some medico-legal cases, certainly where there's complexity, it may be that an expert witnessing care is required.